The appointed time. We just have a quorum, so thank you. This is the last meeting in the year of horse. Right. Yes, tomorrow we have a meeting, but tomorrow's meeting is a special meeting. So do come on time, 9:30. We'll be discussing the regulation on private healthcare facilities. Let's invite the administration in.
羊年係咩啊？唔知年30晚唔知咩已經到。
Year of the Goat? I don't know. Does it start on the last day of this year or what? Let's invite the administration in.
咁咧就上次會議之後，我哋冇特別嘢收到嘅啊。
Okay, no information paper issued since the last meeting. May I welcome Secretary for Food and Health. I was just telling members that this is the last regular meeting in the year of the horse. Tomorrow we have a special meeting. All right, no information paper issued since the last meeting. Oh, I've just been reminded by Madam Clerk that there is a paper provided by the administration on the updated status on the implementation of minor works projects by the Hospital Authority under the one-off grant. Items for discussion at the next meeting. The next regular meeting will be held at 4:30, 16th of March 2015. The administration has proposed to discuss the cross-cluster referral arrangement for public specialist outpatient clinic services of the Hospital Authority and progress of the General Outpatient Clinic Public-Private Partnership Program. Any other suggestions from members? Oh, if not, subject to further changes, these will be the proposed item for discussion next time. Well, we have 3 items for discussion today. The meeting will be adjourned at 7, so do make good use of the time. The first one is measures for the prevention and control of seasonal influenza, and the administration has just tabled some up-to-date information. So over to you, Secretary. Please walk us through the paper. Chairman, I see quite a lot of members here. If you don't mind, I'll skip the briefing. I'll allow members more questions to more members to ask questions. But I'll also ask Dr. Leung to update the figures first. As of noon today, for serious cases under surveillance in public-private hospitals, including adults requiring ICU admission and deaths, there are 9 new ICU admissions or deaths. Cumulatively, there are 300 serious cases with 220 deaths. We have 5 new cases today and 1 reported previously. So altogether, we have 6 additional deaths today. All right. In front of you, we have a supplementary information regarding the latest situation reported by Dr. Leung just now and the year-on-year figures on severe cases during flu seasons. So, speaking time limit 5 minutes each. Dr. Kwokaki, Fernando Zhang, and other members. Dr. Kwokaki first. Thank you, Chairman. When we think about influenza, we'll remember the term social alienation mentioned by Secretary. Not social disorder, social alienation. That was what Secretary said in reply to an oral urgent question. You can't say that the administration has done nothing during the influenza outbreak, but I have to be frank. I think the administration's work is perfunctory. The response is slow. We have over 220 deaths already, as Dr. Leung mentioned, out of 300 severe cases. We've surpassed the figure last year. well, according to government officials and secretary, well, influenza could be fatal. And in previous years, we have deaths as well. But in neighboring places in Taiwan this year so far, there have only been 3 deaths. Maybe this is not up to date, but at least the number is not as staggering as 210, as in Hong Kong. If Secretary only takes a responsive attitude, then the public may be very puzzled, because in terms of the vaccination rate and our awareness of the infectious diseases, in fact, after SARS, after the swine flu, our awareness have somewhat subsided, and the administration should be more active. For example, to do more on vaccination. If the administration doesn't prepare in advance, then towards the end of the season, the figure will not go up. The vaccination rate in Hong Kong at present is just 14%. In other countries, advanced economies, it could be as high as 40%. So I still think that Secretary's response is slow. And on more than one occasion, I have suggested that during the Chinese New Year, more government clinics could be open. Well, in the first day of Chinese New Year, only 20 private doctors' clinics were open. On the second day, on the third day, 61 clinics, and the fourth day, 58. So if there are only 1,500 additional quotas at GOPCs, then first of all, for those sick and frail, they may not be able to consult a doctor, and therefore the A&E unit would be crammed. So the government should do more. We have 70 GOPCs, only 12 will be open. Why is the administration so stubborn and decide not to open more clinics during holidays in view of the recent flu outbreak? Secretary. Well, let me speak first and see if Dr. Zhang would supplement my answer. I thank Dr. Kwok for mentioning once again the phenomenon of social alienation, which I mentioned the other day, and subsequently I noted that there were criticisms that I asked people not to wear face masks because there could be social alienation, but this wasn't what I meant. I said that wearing face masks could lead to social alienation and therefore could reduce the chance of the spreading of flu. So actually, I confirm the function of face masks as being able to prevent the spreading of flu by creating the phenomenon of social alienation. As to whether I should appeal to everyone in Hong Kong to wear face masks, of course we cannot compel that, first of all. And that day I also mentioned that the divergent views among experts. I think the mainstream view among experts is that it's like what I said the other day. Those not feeling well should wear masks. Those at risk groups should wear masks. And if you go to crowded areas with poor ventilation, you should wear a mask. So I thank you for this opportunity to explain my stance. And Dr. Zhang, I'll defer to Dr. Zhang. Now, during the Chinese New Year public holidays, we believe that many private doctors will not be running their clinic. So altogether, we have 1,500 additional quotas at GOPCs. February is the peak season of seasonal influenza, and therefore we also have 1,200 quotas for night clinic. And we also give special honorarium for public doctors to work in A&E units, be they from A&E units or other units. And we also have a list In fact, we've run all the private doctors in Hong Kong. Altogether, there'll be about 340 doctor days during the 4-day Chinese New Year holiday for patients to consult them, and the information will be available online for patients' access. And we appeal to doctors to open the clinics to receive patients as much as possible. Dr. Fernando Zhang, I'm concerned about the disabled and elderly people. The mortality rate at present, according to my understanding, due to flu, is that the majority of the elderly people aged 65 or above, or the disabled with chronic illnesses. Here I see this supplementary information. Over the past 6 weeks, 118 RCHEs or RCHDs had institutional ILI outbreaks, and 722 people were affected. So, of the 725 cases, how many were severe? How many deaths were involved? And I am concerned about these homes. Many homes are private homes with poor facilities. These homes are crowded, and of course they need to follow the relevant guidelines. But if space is not sufficient, how can you ask them to have isolation facilities? Several weeks ago, I asked Secretary at the Council meeting whether you would consider using holiday homes as isolation facilities, just like what we did during the SARS outbreak. At that time, Secretary did not answer me directly. And later, when I checked information, I found that the Lady Macclehose Holiday Center was already notified of its suspension of operation towards the end of December, for it to be converted temporarily as a influenza center.
With regard to my answer last time, I would like to point out that we actually also said this last time. That is about the holiday home. We were doing preparatory work, and it is not for seasonal flu. 2 or 3 months ago, we already got ready, including H7N9, because we have had some imported cases. Some people might have to be isolated. So I took some reporters to these holiday homes as well. I didn't try to dodge the questions. But at that time, we were not making preparation for seasonal flu. We were making preparation for avian flu. So, and for other statistics, I would like to ask Dr. Leung to reply to you. Dr. Leung, can you tell us more about those figures? Let me tell you the overall situation over the past few weeks. When we look at the data, including laboratory data, hospital data, community clinic data, on the whole, they are on the high side, and it shows that flu is still at its peak. It's very active. However, some data also show us that declining trend has started. So on the whole, you can see that the data shows some volatility. And this time around, the flu is particularly lethal because this year the strain is H3N2. When it's compared with H1N1 is more lethal, because for H3N1 it would particularly affect the chronic patients and the elderly. So when we look at the mortality rate, over 90% of the deaths are about people who are about the age of 65, and for those over the age of 80, they account for 70% of the deaths. So on the whole, for the deaths, or for the death, 90% of them are chronically ill patients. And this year, there has been a mismatch of vaccine, so that's why its protection has dwindled. So when we look at the cases, we can see that 20% of the cases come from institutions, and most of the cases come from the communities, and most of them are chronic patients and elderly. And for institutions, no matter whether it's a residential care home for elderly or for the disabled, their vaccination rate tends to be higher, as high as 75% to 80%. So if you look at this figure and compare it with Taiwan, with that of Taiwan or other Western countries, it is comparable. I think for Dr. Cheung's question, he asked it because of your supplementary paper, and that's under B. Residential care homes for elderly or for the disabled, there have been 750 cases. So can you tell us the ages of the patients? If you don't have the information right now, can you give us the information later? Well, for elderly homes, the patients must be about the age of 65. Because for private homes, they are very constricted. There's not enough space for them. So what kind of measures are in place? Oh, should they be placed in holiday homes instead? Maybe I can supplement. When it comes to institution, if they are in the same room, then maybe we can make on-site arrangements, maybe putting the patients in another room, etc. If several persons show symptoms, that means that there has been a certain degree of spread. So no matter whether it's an institution or a school, when there's a problem with a room or a classroom, we would implement measures so that the people in that room or the students in that classroom would not come into contact with the rest of the people in the institution or school. Maybe I can also share with you, I don't have as much experience as Mr. Leung, but the year before last, I went to an institution with Dr. Leung for a drill. Now, if in an institution there is more than one person that is infected, of course, we do not mean very severe cases. If it's severe, then the person has to be hospitalized. But he's not severe and he's infected. And if several persons share the same room, then for all those infected persons, they will be placed in the same room and they will be isolated from the others. And if only one person is infected, and if then we may not put him in a room, because we're talking about droplet infection, not air infection. So we would screen that person off, and we would encourage the use of mask and hand washing, so that patient has to wear a face mask, and he also has to wash his hands frequently. When it comes to holiday homes and making use of them for isolating patients, but most of the time we won't use it for flu cases. Mr. Poon Chiu-ping. Well, for the peak of flu, we've heard from the administration. We don't know whether we are at the very pinnacle yet, so it's worrying. During the Christmas holiday, the A&E department was under huge pressure. And in those 2 days, 12,000 people attended the A&E departments. So we are worried that for the Chinese New Year, the A&E department will also be under huge pressure. So from the 21st of December to the 28th of January, on the average, more than 1,000 people attended the A&E departments. So other than local residents, have there been non-local residents visiting the A&E departments? Has there been such a classification? I'm not saying that they cannot use our A&E departments, but what I mean is that during holidays, a lot of visitors would come to Hong Kong. And would they be bringing flu to Hong Kong? Do you have this kind of information? And also the Secretary has repeatedly said that, well, for flu, the best prevention is vaccination. When we look at the information, over 400,000 doses have been used. So will you do more promotion so that more people will receive vaccination? And how many doses do we still have? And do we have the capability of manufacturing these vaccines? Now, let me answer the question concerning vaccines first, and then Dr. Leung will be talking about the A&E department. As for vaccines, well, this may not be the most updated figure. For the vaccination season, actually, we are nearing the end of it. At the end of January, I looked at the situation and I asked the hospital authority as well as the Center for Health Protection. At the end of January, the two institutions had a total of 40,000 doses. Yes, this vaccine may not be very protective. However, if it offers 20% extra of protection, that will still be good. So that's why the HA focused on high-risk cases. Last week, when I asked the HA, only 10,000 plus doses were left. And the HA asked the CHP to look for a supplier, and then it got an extra amount of over 10,000 doses. So in total, the HA would have around 50,000 doses, and most of these will be used on at-risk patients or at-risk persons. We are still calling on people to go to community clinics or private clinics for vaccination. And with the advent of February and March, we will be seeing the end of the epidemic, although we do not know whether this time around the epidemic will be lengthened. As for severe cases and deaths, the figure is still on the high side, but when we look at institution outbreak, the number has dropped. So what shall we do for the next wave? It is not about the remaining doses. It's about finding new vaccines which would match the circulating influenza H3N2 Switzerland strain. We have contacted some pharmaceutical companies, but they are not manufacturing the products for us, because for the Northern Hemisphere and Southern Hemisphere, the WHO would look at them in terms of a half-year period or season. I have talked to Dr. Margaret Chen. She said that for the Northern Hemisphere, every February, she would look at the situation, because normally it would be the peak of flu in the Northern Hemisphere. And then they would be looking at the circulating flu strain, and then they would decide that for the end of that year, what kind of vaccines should be used. Why would they have to decide in February? Because they have to give half a year to the manufacturers. So in February, they already issue the guideline, and the manufacturer would manufacture for half a year. So in October, we will be getting that vaccination for the coming winter. In the Southern Hemisphere, it's half a year later. So in September or October, another guideline will be issued, and the manufacturers will again be given half a year to manufacture vaccines. And these vaccines will be used in June in the Southern Hemisphere. So for these vaccines that are going to be used in the Southern Hemisphere in June, it is for H3N2. We have found a manufacturer who is willing to manufacture extra vaccines for us, and we are now trying to get more. However, the amount will not be sufficient for everyone in Hong Kong because it's in between two cycles. And according to the experts, the seasonal influenza vaccine SIV will have an effective period of about 6 months. So when we have the new SIV who will be vaccinated, and actually it will be used to fight against the peak in this summer, and we hope that we can also tackle the peak by the end of the year. But I think tomorrow our experts will have a meeting, and they will discuss that. Well, because when the SIV comes, the amounts will be limited. They would also have to consider the effects of vaccination, because earlier this year some people have already been vaccinated. So shall they also receive this new SIV later this year, and will that be helpful, and will the new SIV protect them until the next peak, that is at the end of this year? The experts will be discussing about this tomorrow. So for NEP, will that be the source? Well, for the peak season is 5,600, and last time around is 7,700 to 7,500. And our computer system has the relevant figure, but I do not have them in hand.
Yeah, Mr. Poon also has another question, whether we'll develop our own vaccine. Yes, on developing vaccines. Earlier, university professors indicated that we could develop vaccines in Hong Kong. However, before that, I already knew that some scholars in Hong Kong did take part in collaboration projects with other overseas experts in research on vaccines. And our research capability is top-notch. We have the capability of developing vaccines, and we have been talking to them, and the government will work with them when necessary. And we also have the funds available for the research. And I want to point out that over the past 2 years, the government has been subsidizing the 2 medical schools in Hong Kong in the setting up of phase 1 of the clinical research center with our medical funds. This will help our the academic sector in the vaccine research. However, in terms of production, we need to consider the scale of production. We need investment. We're talking about some 2 million vaccines. That's our demand in Hong Kong. But for a sustainable production line, in order to have some economic benefits, we need a scale bigger than that. So unless the manufacturer can tap a bigger market, it will be hard to find someone to invest in the production of vaccines locally. So we have 2 points of consideration. First, the registration process. A vaccine is similar to a kind of drug. We need to register the vaccine elsewhere, and we need to meet their requirements. Secondly, whether there is any market. If there is already a vaccine available in that market, then will the market still be able to register our vaccine? Mr. Albert Ho, 300 deaths That's the latest figure as of today. No, over 200. Over 200, right. 299 deaths during SARS. Is that right? Now the number of deaths is on the rise, and many people are getting more and more concerned about this. It's hard to compare this virus with the SARS virus in terms of the infections and the mortality. However, I see the government has raised the alertness level, the response level to serious, and the public hospitals have also been more vigilant. I'd like to know our capability with more people using the A&E units. What is your estimate? I don't know whether the Princess Margaret Hospital's annex building have now been commissioned. I'm asking whether we have capacity in handling the outbreak. What about other drugs, Tamiflu and other drugs? Do we have enough on our reserve? Any problem with that? And thirdly, people are very concerned about kindergartens and other places where there are more children. And under what circumstances should there be a class suspension? Will there be any guidelines? A number of questions. First, on seasonal influenza and its difference with SARS. Well, I'll ask Dr. Leung to explain the difference in a moment, but I want to make a comment here. For seasonal flu, as Dr. Leung will be suggesting in a moment, the feature is that you will see tens or even hundreds of thousands of patients. But in terms of severe cases or deaths, the ratio, the percentage is actually low. But I cannot say that we can relax our efforts because the rate is low. Because, as I said in the beginning, there are actually over 200 deaths already, and we must not underestimate the issue. Now, I'll defer to Dr. Leung on the other issue, in accordance with our response plan against influenza epidemic. We all along have stocked sufficient drugs, so there shouldn't be a problem. Class suspension for pre-primary or primary schools, we have guidelines. Maybe I'll ask Dr. Leung to speak on capability or capacity and the supply of drugs, the difference between SARS and seasonal influenza and guidelines for schools. Now, one more point. If somebody is diagnosed as having the influenza, under what circumstances should the patient be admitted? I'll defer to Dr. Leung as well. Now, first, about seasonal influenza and other forms of influenza like bird flu or SARS. Now, the pressure on our capacity is on the general wards, ICU, A&E, and therefore we see the request for additional beds, additional manpower, and we face pressure in this regard. As for other forms of influenza, we need isolation facilities. Generally speaking, we need isolation facilities in the Princess Margaret Hospital, and in fact, we have over 1,400 beds as isolation facilities after expansion and redevelopment projects, and this is for other infectious diseases. And so far, we're dealing with a seasonal flu, and the Center for Health Protection will also talk, or is responsible for the stocking up of drugs. About schools, Now, about the major differences between SARS and seasonal flu. SARS is a severe disease. The mortality rate is as high as 17%. Once a patient is affected, the situation is severe. Hospitalization is needed. Regardless of age or other features, anybody can be affected. As for seasonal flu, the mortality rate is less than 0.1%. And during peak seasons, many will be affected, but not many may require hospitalization. The percentage of deaths is also much lower. Apart from severity, there are vaccines and drugs available for seasonal influenza. For SARS, we didn't have targeted drugs, we didn't have vaccines. Seasonal flu affects mostly the chronically ill and the elderly. We have 19,000 doses of drugs to tackle seasonal flu and to tackle the possible epidemic globally due to any mutation of virus, so that the at-risk groups could be given the necessary drugs. But this is about the influenza epidemic, and we've recently started our response plan in relation to chickens and other poultry being found with the virus, and that's basically the purpose of the plan. As for class suspension, in 2009, guidelines were issued in relation to primary schools and pre-primary schools. Situations with infectious diseases. For example, if in a short period of time there are 3 cases of infections, then the CHP's help can be sought, which can gauge the situation and give advice. Depending on the number of people affected, the severity of the infectious diseases, and whether the situation is under control or not, we may advise the student concerned not to have any contact with other schoolmates, and if the whole form or the whole class, if the whole form is infected, then depending on circumstances, the whole school will have to be suspended. We still have a number of members waiting to ask questions. Mr. Yu Si-wing. Well, recently I received some information regarding the Hong Kong Medical Association information on private doctors working during the 4 days of public holiday during Chinese New Year. But I see that some clinics are not open until the 3rd or the 4th day of Chinese New Year. And the pressure, therefore, will be on public hospitals and A&E. And there could be a bigger problem for public hospitals if the triage system is not implemented properly. Have you discussed with the private sector whether there is any collaboration mechanism so that even during Chinese New Year holidays, in certain districts, some clinics can stay open, so that patients don't need to go to public hospitals? Secondly, according to information, the government has a mechanism in monitoring the situation of influenza across the world. We also maintain close liaison with your counterparts in Macau and the mainland. And just now the other member said that in Taiwan only 3 people died of flu, whereas in Hong Kong there are already so many deaths. Hong Kong is such a crowded place. and we now have a situation of influenza. Should we draw reference from other countries? Has any research been done? Any outcome? Secretary, thank you, Mr. Yu, for your question. I'd like to say that different countries, because of different geographical locations and demographics, may not be right for us to compare the situation. I'll defer to Dr. Zhang to address your first question, and I'll defer to Dr. Leung to explain the second question to you. Yes, about the first 4 days of Chinese New Year, it is important for private doctors to open their clinics to meet public demand. The Hong Kong Medical Association conducts an annual survey, and the private doctors would return the questionnaires telling them when, during the Chinese New Year holidays, will their clinics be open, and the information will be uploaded on their website. And I thank the Hong Kong MA for their work, but this is done on a voluntary basis. As we anticipate that the influenza situation is serious this year, we've asked the association to ring all the doctors in the 18 districts, and many private doctors have responded whether they would open the clinic during the Chinese New Year holidays, and we've managed to get more information than the lists are given by the Hong Kong MA, and during the first day of Chinese New Year, 39 clinics will be open, second day 69, third day 109, and the fourth day 122. And the information will be uploaded online so that members of the public may check if a nearby clinic is open or not. Comparison with other countries? Thank you, Chairman. But we need to consider different factors when comparing figures with other countries. In Europe, in the US, and Canada, 90% of the flu is H3N2, the Switzerland strain. But in the northern part of China, for example, slightly over 50% is H3N2. And as I said just now, H3N2 may cause a more serious condition. For H1N1, the rate may be lower. In terms of incidence rate, mortality rate, we cannot just compare figures. We need to look at the demographic situation of the place, and it's difficult to compare the absolute numbers. We need to compare the rate as well. We also need to compare or consider different time frame. In the northern part of China, for example, the peak may begin in the end of November, but in Hong Kong, the peak may not begin until January. And in the northern part of China, it may begin in the end of November. In the southern part, their peak may come later, around March.
As for Taiwan, it's later this year. In the past years, it was earlier than Hong Kong. However, this year is quite late. It started in the middle of January. So many factors have to be taken into consideration. Mr. Bang Chen, just now we were given a figure that is from the first to the third day of the Chinese New Year, we'll have 340 doctor days. So for the first day of the Chinese New Year, most of the private clinics will not open. So for the A&E department, what will the arrangement be for public hospitals? Some people may have to be hospitalized, but will the hospitals be very full? Can you tell us the arrangement? And also for the healthcare workers, 30% of them have been vaccinated. And in other countries and places, about 60% of the healthcare workers would be vaccinated. So this is not ideal. We do not have enough manpower in our healthcare sector already. What if we have more patients and the healthcare staff are sick? So how can we improve the vaccination rate of healthcare workers? And also for some hospitals now, they are already saturated, and some patients have to sleep in the corridor. And when it's so crowded in hospitals, flu may become more prevalent, and there may be an even bigger outbreak. So what's the contingency plan on the part of the hospitals? Dr. Zhang will answer these questions. During the Chinese New Year, yes, there will be less private doctors working, and we expect that more patients will visit A&E departments. So we have already launched a plan that is for A&E doctors as well as non-A&E doctors. If they are willing, we can provide them with honorariums, and so that they can work in A&E departments. They can handle the non-urgent cases. So for the capacity of A&E departments, it will be enhanced during the Chinese New Year. And we have asked the doctors not to take so many leave days during this year. And actually for the first and second day of the Chinese New Year holiday, situations have not been too serious. Usually it's the third, fourth, or fifth day that would be more problematic. And also we have added more beds. And during the Chinese New Year, normally we do not do non-urgent surgeries, because even for patients, they do not want to undergo operations during the festival. So we can make use of those beds. And we can also add 200 more beds to our existing system. I think we may have enough supply of beds, but of course the wards will be very crowded. As to whether there will be flu inside the hospitals, well, there is one thing very important, that is preventive measures must be in place, because now we are already at a serious stage. So we have already stepped up our preventive measures. When you go to hospitals, you can see healthcare workers wearing masks and washing their hands with alcohol. So we are trying our best to handle cross-infection. As to whether vaccination rates for healthcare workers will be increased, well, it's actually a voluntary program. We have 400 points in all the clusters, which would provide vaccinations for healthcare workers. And next year, if the strain match is better, I'm sure more healthcare workers will be willing to receive the vaccines. Well, according to the tabled figures, in 2015, the HA flu death rate is about 4.2%. So is it a historical peak? And how should we interpret this percentage of 4.2? Well, if you look at the 2015 figure, 95% of them are caused by H3N2. As for 2012, for the first 3 months it was flu B, and then later it became H3N2. If you look at the fatality rate, these 2 years are similar, but over the past 3 years there have been some major changes. The number of elderly has increased significantly. From 2011 to this year, according to the Census and Statistics Department, we have 130,000 more elders. So many of the people affected are elderly this year, in particular for those over the 80s. Over 70% of the deaths are people over the age of 80. They are the risk group. And when there is a serious flu, the risk groups will suffer more. So towards the end of the season, we'll look at the fatality rate again, and then we'll be looking at the demographics, the cases of death, and then we will make clearer comparisons. This table just shows that for the H3N2 years, cases may be more serious. Well, for Mr. Ben Chen's question, he asked about the vaccination of healthcare workers. Well, I think in Hong Kong, yes, this is really far from ideal. Our vaccination rate is low. The same for ordinary people and healthcare workers. And according to Dr. Cheung, the HA has provided many convenient ways for the healthcare workers to receive vaccination. And we, the people at the management level, have already set an example. But we do not want to mandate the professional workers to do this, because they also are professionals. They can make their own judgments. This has given us a headache. We really have to come up with a way to encourage more healthcare workers to receive vaccination. Well, as for the people living in institutions, according to Dr. Leung, 70% of the people living in institutions have received a vaccination, and we are trying our best to vaccinate the at-risk groups. And this year we should come up with a method to enhance the vaccination rate significantly. We have already started our discussion. We hope that the whole overall vaccination rates can be improved. For the first day of the Chinese New Year, it may not be the peak. There are two reasons. Many people are out of town, and second, due to customs, people do not normally go to a doctor on the first day of Chinese New Year. But of course, people will make their own judgments. I now call on the public that if you think you are really suffering from serious symptoms and you need to see a doctor, please do not wait. In particular, when it comes to flu, the first 24 to 48 hours are very important, and the SIV or the medication would work best in the first 24 to 48 hours. Well, for healthcare workers, not many of them receive vaccination. In the past, it's 40%, and in overseas, it's 70%. And in some U.S. hospitals, sometimes all the healthcare workers are required or mandated to receive vaccination. The secretary said that's because, well, the healthcare workers are themselves professionals. They can make their own judgments. So why can't we mandate them to do this? Because if they are affected, the hospitals may become affected zones. So if they are in this profession and if they do not trust the SIV, then how will the ordinary people believe in the vaccine? So how can you encourage more healthcare workers to receive vaccination? Should you really mandate it? Because I think in the U.S. some places really mandated. Is this feasible? And second, now we are talking about H3N2, and we will not forget H7N9. There will be cross-infection. Live chickens are sold in Hong Kong again now. So if there is a cross-infection, will there be a new flu, and what kind of measures will be in place then? Secretary? Thank you, Mr. Chen. Just now I said that it is a headache for us. Today I cannot give you an answer. We have to pull the wisdom of the mass. And if you have views, please let us know. If you want us to mandate it, I think we have to look at one thing very clearly. We got patients' rights, so we cannot force people to do things. This is not a small issue. Now, we have to attach importance to patients' rights, and also in terms of law, we also have to clarify things. Now, if we can come up with better ways, we will not mandate healthcare workers to receive vaccination. We already have a team working on this. We hope that in the coming years the vaccination rates can be much higher. As for H7N9, yes, whenever there's a seasonal flu outbreak, some patients may at the same time suffer from avian flu, and if the patient suffers from two kinds of viruses, there is a possibility of a genetic reassortment. So we have been very careful about our chicken measures. And if you look at the statistics, we haven't seen people infected with HN79 that comes from chickens. But for the Chinese New Year, our citizens may go to visit the mainland. They may not heed our advices, and they may come into contact with live poultry, birds, or go to live bird markets, and then they come back to Hong Kong. They may bring back bird flu viruses, and we have seen this in the past before. Now, if professionals like you are willing to be vaccinated, then it's very encouraging. Otherwise, the general public would not heed your advices. Yes, we understand. We will try to come up with a way.
Dr. Helena Wong, 2 questions. First, about Chinese New Year holidays. Only 13 GOPCs will be open. Is that right? Will you consider opening all 20 GOPCs? Secondly, about flu shots. Now, people are struggling with the idea of whether to receive the injections or not, because it's said that the vaccines only offer 20% protection due to a mismatch, and Secretary said that the new batch of vaccines won't be available until April or May. So how many such shots are we talking about? And what about the supply of new vaccines? Will they be able to cope with the next peak in July and August? Because, well, if supply is insufficient, then what can be done? We're using trivalent, quadrivalent at the moment, and some members of the public may say that after receiving a trivalent shot, it will be just for coping with this peak. So should they require a new vaccine at the next peak? So they're wondering if they should wait for the next vaccine to be available. But when the next vaccine is available, they don't know whether there'll be sufficient supply for them. Secretary. Well, thank you, Dr. Wong, for your question. I'll answer your first question. I'll defer to Dr. Zheng to answer the next one. I stand to be corrected. We're talking about the trivalent and quadrivalent vaccines for this peak, and that includes H3N2, but not the Swiss strain. So we have trivalent and quadrivalent vaccines. In April or May, we may be able to get another trivalent vaccine, which includes the vaccine for the Swiss strain. And the expert committee will hold the first meeting tomorrow. I don't expect them to solve all the problems at just one meeting, but the first meeting will be held tomorrow, and I can't tell you the exact figures here because we're still striving for more. We want to get as many as possible, but since the manufacturer is only manufacturing for us in addition to their normal production, the amount won't be great. Tomorrow, the experts will be discussing one issue, and you've pointed out very correctly. Should those who have received trivalent or quadrivalent vaccines be receiving the next batch of vaccine shots again? So I can't ask you now. We need to wait for tomorrow's discussion. About the period of protection, normally it's between 6 and 9 months. So if somebody receives an injection of the new vaccine, then how long will the protection last? Will it last till September? So if the experts agree that for the new batch of vaccine, the protection period can last till September, then the vaccine can more or less cover the next peak, and those who have received vaccines will not require another shot. But that depends on whether the next virus strain will be similar to the Swiss strain. So the expert committee will have to meet more than once to come up with anything. But they still have time because we're talking about the next batch of vaccines being available only in April. Now, whether people should get flu shots, well, we can't help them decide. But I think for ordinary members of the public who are not in the at-risk groups, they may receive the shot nonetheless, because the expert committee may deliberate on the issue and may advise those at-risk groups to receive the shot, and those not in the at-risk groups may have received the vaccine in advance. And so for the other waiting, they may receive the shot once they're available in May or June. We have 12 GOPCs during the Chinese New Year holidays, which will be open. And I think people are very familiar with these 12 GOPCs because they usually open during festive seasons. And we're talking about 1,500 additional quotas for these 12 GOPCs. Now, on whether we can open more GOPCs with the use of the 1,500 additional quotas, we're concerned if people don't know other GOPCs may be open, it may go to waste. Mr. Wang Ting-Kwong. Well, I really appreciate the work of the Food and Health Bureau. Of course, we can always have improvements. Now, I am somewhat puzzled, and I have a question for you, Secretary. I recall when I was young, when I was just a student, an ignorant young student studying primary 1 or 2, we had snots on our nose, and I recall there was a flu epidemic, and we didn't even have tissue papers. We had handkerchiefs, and our mothers would wash our handkerchiefs with disinfectants. Now, your Western medicine doctors have done a lot to combat flu, but I don't see anything done by the Chinese medical doctors. There are different ways, alternative ways of dealing with plagues, so to speak, or epidemics in the community. Have you considered seeking help from the Chinese medical practitioners so that they have a role to play? Have you considered, Secretary? Thank you, Mr. Wong. Perhaps in the mass media, you haven't heard of any publicity on the promotion of Chinese medicine. But in fact, our focus is quite a narrow one. What we're focusing on is severe cases requiring ICU or hospital admission. But in the community, actually, tens of thousands of people have been contracted with flu. So I quite believe that our Chinese medicine practitioners in the community have already dealt with quite a lot of flu cases. Well, whether those incense would be useful. As Western medicine doctors, we won't go out and publicize the use of that because we're still discussing and researching on influenza, and there are experts who say that because of the antigenic drift of H3N2, the vaccine's protection have dropped to 20%. And according to the research in other countries, the figure has dropped to a single-digit one. So we need empirical research as our basis in Western medicine. Every time I need to tell others what our basis is. 20% is better than nothing. For those without clinical proof or empirical proof, we mustn't publicize them. Well, when it comes to Chinese medicine, I'm sure that they deal with a lot of cases. And in terms of our surveillance program, some Chinese medicine doctors have also taken part in our surveillance programs. Dr. Zhang, have you taken part in publicizing and exercising surveillance on the Chinese medicine clinics under HA? Yes, over the past few months they have become very popular. Will they be open during public holidays? I don't have information at hand. I'm happy to hear Dr. Kuo just now talking about Chinese medicines, treatment, and its contribution to a flu epidemic. I think this is the first time in this council that you talked about the use of Chinese medicine in combating seasonal flu. Of course, we don't know whether those the incense pouches would be useful. But in the herbal shops in the community, sometimes they give a sachet of medicine for flu. I don't know whether, well, I haven't been contracted with flu yet. I don't know whether it has to do with those sachets. My wife, my chief executive at home, so to speak, from time to time would force me to drink such tea. I must respond because your chief executive at home may be very familiar with your physical condition, and I shouldn't comment. But from the point of view of healthcare, well, even if you take Chinese medicine, you should consult the Chinese medical practitioners because it depends on the physical condition of the patient. In the past, some Chinese medical doctors have advised that in relation to some popular over-the-counter Chinese medicine to combat flu, it may not be appropriate for certain people with certain physical conditions. So, Mr. Wong Ting Kwong, please go back and advise your chief executive at home not to force you to take those medicine. Miss Alice Mack, well, nobody forced me to take that medicine. Well, anyway, I see Secretary and his team has really made a lot of effort in combating seasonal flu, and their work should be supported. Now, there are different messages in the community. Some are advising the use of face masks. I think this is the prevailing message. Washing your hands, using sterilizing hand rubs, etc. These messages are not very clear. On the contrary, we see lots of people wearing masks on the street because I don't want to be the source. I don't want to infect others. So in terms of publicity, apart from wearing face masks, I think you need to send a stronger message to the community that they should wash their hands. And I think Dr. Kuo and Dr. Zhang should also follow up on the issue of locally developed vaccines. Our vaccination rate is not high comparing to other countries. Many parents, in fact, refuse to take their children to get shots, not just for seasonal flu, but for other vaccines, because they've heard that those vaccines may cause side effects such as fever, allergies. So, Secretary, you should send a stronger message to educate the public on the use of vaccines. Nowadays, people prefer alternative therapies. They may think that the vaccination is bad. Well, also, please listen to the FTU's views. Last week, we already came out and commented in public that healthcare staff is working very hard. You really have to resolve the issues of low staff morale, same job, different pay, remuneration, meal breaks. All these arrangements are different across clusters, and healthcare staff is now putting up with all these problems. But you have to address the issue of low staff morale.
With regard to washing hands, maybe you haven't paid attention to this. In the past 2 or 3 months, we have had an API. We have asked Dr. Leung, Dr. Zhang, and Dr. Chen to tell people how to wash their hands. And of course, we also hope to come up with more creative ways to encourage people to wash their hands. As for SIV, yes, it's true. Now, if you are in the medical profession, so you can find people who do not really believe in vaccines. But for the mainstream medicine, most people would believe that there are positive impacts would outweigh the negative impacts. In the coming year, we will do better, and in the interim, we will just be able to find a small amount of SIV, and those will be given to the risk groups. But for the end of this year, we are now trying to come up with a way so as to significantly increase the vaccination rates in Hong Kong. And speaking on behalf of Dr. Cheung, I would like to say this. we have been talking to the HA all the time, and we understand that they are adopting different measures. And also, the HA itself has talked about it. I have visited the 7 clusters, and I have heard similar views. I have relayed those views to the HA board, and I'm sure they will try to solve the problem step by step. Dr. Fernando Cheung. Chairman, I'm also worried about the manpower and the crowdedness in hospitals. As I've heard, some patients have to sleep in corridors and hospitals, and I'm even told that beds have to be set up outside toilets. And we don't know when this flu will peak. So how can you improve the crowdedness and manpower shortage in hospitals, in particular for for A&E departments and the medical wards? The utilization rates are very high or even exceeding the ceiling. So in the long run, how can you solve these problems? Dr. Cheung? As for the overall shortage of manpower, yes, we are conducting a review. We are trying our best to make improvement, and Dr. Cheung will give you a more detailed answer. Yes, well, we have a huge demand, and the wards are very crowded. Yes, these are not ideal. So this year, in 2014 to 15, we already have a plan to step up our contingency measures. Early this year, we already opened 200 permanent beds, and 280 time-limited beds are also opened, and they will be serving for a period of 6 months. Unfortunately, the demand is exceptionally huge this year, so even with the addition of 500 beds, we still find hospitals very crowded. And we are now still trying to increase the number of beds. So we are under 2 restrictions, that is manpower and space. We do not want wards to be too crowded either. So other than adding beds, we will also be redeploying resources. So for some non-urgent services, we may be reducing them so that we can focus our efforts on flu. And we also want to thank our frontline healthcare workers. And you talk about pay as well as welfare. Well, of course, we will definitely take them into serious consideration. As for anti-flu vaccine, yes, we understand the WHO has made a wrong guess, and there is also this antigenic drift this year. Well, sometimes the pharmaceutical companies are very influential, and I think Hong Kong has to assess medicine independently. We need to nurture talents in this area, or we may even have to build a center. And maybe ourselves in Hong Kong should be doing some R&D. Secretary? Earlier on, I mentioned that some academics in Hong Kong have already expressed their views. Maybe in Hong Kong we can do research or even develop vaccines. When it comes to virology, Hong Kong is one of the top places in the world. We have some medical research funds. Our academics can apply for these funds for R&D. I understand that some academics have already done so. In the past 2 years, at the 2 medical schools in Hong Kong, we set up a clinical scientific research center, and this has also enhanced our capability in terms of vaccine R&D. But if such vaccines are to be manufactured in Hong Kong, there will be problems because huge investments has to be made, and they need land, and also there must be an economy of scale. But in Hong Kong, we only need several million doses. And for an industrial production, you need a much bigger amount. So therefore, they need other markets other than Hong Kong. So they have to consider the registration procedures because this medicine is to be produced in Hong Kong, and can it be registered in other places? You have to consider the other markets. Do they need such vaccines? If those markets have a huge supply of their own vaccines, then the manufacturers cannot tap into that market. But of course, in Hong Kong, if we invent a vaccine that is unique, you cannot find it anywhere in the world, then of course it's different. But if you are talking about developing a vaccine in Hong Kong, which can also be developed elsewhere, then it may not be that marketable. Dr. Kwok, when I look at the figures, the government says that on the first day of the Chinese New Year, 39 private doctors will be providing services, but it's only 2% of all the private doctors. And the government insists that only 1,200 quotas will be added. I think that's not enough. And also about beds. Well, for QEH, their attendance rate is over 110%. This is not a news. The government says that it has done a lot. However, the attendance rate is still as high as 110%. Why is that? In particular, for medical ward inpatients beds, I think there is a serious shortage. I don't want the government to come tell us every year that the inpatient occupancy rate is always higher than 100%. I know that patients are sleeping in corridors or sleeping near sluice rooms, which handles waste. So for the vaccination rate, so you have a target. In about 2 months' time, you have to place your order. Then by the end of this year, you can get vaccines. Now, if you have no targets, then it will be the same next year. And private doctors would not just order their own vaccines without any instruction. Now, we are talking about over 200,000 doses, and they will be administered by the government. And then there is also a seasonal influenza vaccination program. So what are the targets of the government? For vaccination, we agree that the present vaccination rate is not ideal. So no matter whether it is for the healthcare workers or the at-risk groups, I think that we have to significantly increase the vaccination rate. And internally, we have already started a study. We try to find out ways to significantly increase the vaccination rates in the coming year. So this is not about an ideal. We will try to think. We will come up with ways. For example, the whole flow was, will we be visiting the risk populations? Will we be cooperating with the private sector, etc.? So if you have any suggestions, please let us know. This is definitely our goal. As for the number of beds, After I've assumed the post, I've been looking at the figures. Yes, we have a serious shortage of beds. This is not that difficult to comprehend. Now, in the past 2 years, we had a new hospital. That's the North Lantau Hospital. And when was the last one before that? Cheng Kwan O Hospital. Cheng Kwan O Hospital was opened before 2003. I cannot remember in which year it was commissioned, but I remember in 2003 I went to Cheng Kwan O Hospital to visit the ICU because of the SARS outbreak. So there was a gap of 12 or 15 years without any new hospital. I say that the greatest opportunity is at Kai Tak. We should have a mega hospital there. Of course, we are not just talking about hospitals on the Kowloon side. Earlier on, we have already put together a blueprint. Of course, it's just an initial one, but we will develop it to make it more concrete, and we will be reporting to this panel on a regular basis. And for the Prince of Wales Hospital, it has started its phase 1 expansion, and it has asked the HA to plan for stage 2 right away. And in Taipo, there are 2 hospitals. We need expansion. For North District Hospital, it needs expansion. And we are talking about opening a Tin Shui Wai Hospital. After the initial 300 beds, we need expansion right away. So you can see that in the coming years, we need to catch up. So for both private and public hospitals, we need to add more beds. Secretary, I also want to ask about vaccination. I remember the last government bought a huge amount of SIV, but most of it was dumped. They were not used. So if people do not take the vaccination, the SIVs would have to be thrown away. Yeah, sometimes there is supply shortage, and sometimes after we've bought the vaccines, they may not be used. After the SARS outbreak, we have stockpiled a lot of antiviral agents. They have not been used. But we need to have a contingency plan. So that's why we always have to stockpile more.
But as I said just now, next year, if we're to boost the vaccination rate, there is also a concern whether we can source adequate vaccines. So I can't tell you we can do a very accurate estimation. We'll just try to be as relaxed as possible in the procurement of vaccines. And we'll also adopt a very proactive thinking in promoting vaccination. Well, we've had ample time for discussing this item. We've discussed for 1.5 hours. So I thank Secretary and your team for attending. Next item is on Sentinel and Serious Untoward Event Management in the Hospital Authority. We have 2 items to go, and our meeting will be adjourned at 7. The last item is on research study on regulation of aesthetic practices in selected places. And we do need more time for Sentinel and Serious Untoward Event. Perhaps we should discuss the final item at the next meeting. So I'll see if members object. I agree, but it's a very comprehensive report. So perhaps next time we can hold a public hearing and receive deputations. And I think, on the other hand, we should have a discussion first. We can have a public hearing. I think we can discuss the paper first, and if necessary, we can then hold a public hearing. If we have both in one go, it may be a bit confusing. So we should discuss first and then wait for the administration to respond, and if necessary, we hold a public hearing. We can spend more time on this item. So I should do some housekeeping here instead of letting government officials wait till 6:45 and then tell them we don't have enough time to discuss this. So we find another occasion to discuss this item. So would the staff please inform the relevant representatives from the administration that item 5 will be deferred. And then we'll focus on item 4. Sentinel and serious untoward events management, the HA. Anything to supplement? Yes, allow me some time to walk members through the paper, and then Dr. Au will also supplement. Now, members, the HA has all along attached great importance to the quality of its services and patient safety. We have 6 million plus SOPC attendance and 1 million inpatient attendances, and we provide quality services, and we have a mechanism of handling medical incidents. In 2004, we introduced the Advanced Incidents Reporting System AIRS to enable frontline staff to report incidents directly from their workplace. And we also we've also introduced the SE policy and SUE policy. And then within 24 hours, the hospitals are required to report all sentinel events, SEs and SUEs, serious untoward events, to the HA head office and handle them in accordance with the established procedures. Apart from giving support to the relevant patients, family and staff, we also encourage open disclosure of the incidents so that lessons can be learned from the events to prevent similar incidents from happening in future. The HA also has a clinical team, and the team has implemented the measures in ensuring safety and quality of services, and the details are set out in paragraph 16 to 18. I won't repeat the points here. In short, we have a quality and safety scheme in HA head office and cluster hospitals so as to give inspections, clinical audit, and a plan to improve quality of service, and also to introduce a mechanism for the review of medicine. After implementing the relevant measures, we also have we also face the relevant risks. Since its introduction in 2007, the HA still records 20 to 40 such SEs every year, and in 2013-14, 49 cases were received. The number was on the high side, but comparing to the attendances of 1 million, the rate is 2.5%, which compared to other jurisdictions with similar mechanisms of SEs and SUEs, such as Victoria, Australia, the rate is 23. Australia, Western Australia, 25.5. Hong Kong actually fares quite well. And as for details of the sentinel events this year, maybe I'll defer to Dr. Derek Au, Director Quality and Safety of HA, to walk members through the situation. In January, we submitted an annual report to the HA on sentinel events and serious untoward events. We reported on the 9 categories of incidents and the 2 categories of serious untoward incidents or events. And before disclosing each incident, we followed and analyzed on the reasons for these incidents, and in the report we give an overall response and see whether we should improve on the system, taking into account the similarity of incidents. And as for the number of events, because of the small base number, we cannot conclude whether the number, which is on the high side of this year, is becoming a trend. As for SUEs involving medication error and misidentification, the figure has dropped. A number of trends can be identified. For the majority of cases, they have to do with death of inpatients from suicides, including home leave, as well as retained instruments or other material after surgery or interventional procedure. These are the two major categories, and we've done some analysis. In answering members' questions in a moment, I can go into more details. And we need to consider whether this is or will become a trend, whether the situation has deteriorated. The report covers the fourth quarter of 2013 to the third quarter of 2014, which means that after completing the report, we do have some up-to-date figures since the fourth quarter of last year and the first quarter of this year. In the fourth quarter of last year, we recorded 9 SEs, and in the 1.5 month this year, we recorded 2 cases. So, judging from these figures, the level has dropped to those previous years, quite a normal trend. So we can say that this may not be an upward trend. As to what can be done in different categories of cases, perhaps I'll take members' questions in a moment. All right, we have Kwok Kak-ki, Poon Siu Ping, Alice Mack, Dr. Helena Wong, Fernando Cheung, and Mr. Ben Chen. 5 minutes. Dr. Kwok Kak-ki. Well, I can confirm the effectiveness of the advanced incidents reporting system because it is an important step towards making these incidents more transparent. However, disclosing such incidents doesn't mean eradicating the problems or preventing such incidents from happening. Now, some figures are really staggering in the paper. For example, for SEs in 2012, there were 26 cases. Of course, there were fewer events that year, but this year we have 49 cases. For SUEs, the figure remained more or less the same, although the rate is not high. At least in the minds of the public, some incidents are really unacceptable, in particular on medication error. The HA has implemented a medication matching procedure for 20-odd years already, and still the number is relatively large. Be it the previous year or the year before, there are 5 such cases in 1 year, and these cases should not have happened at all. So what has been done? And secondly, about some systemic analysis. Now, the incidents have repeated year after year. It hasn't only to do with manpower. It is impossible for HA to have adequate manpower anyway. So it has to do with the system. Has anything been identified? Thirdly, now this is the categorization by HA. I'd like to know whether those figures have really dropped. I think for fellow members, we do have at hand some cases of complaints that we receive every year. Now, some patients may perceive their cases as serious. Maybe the categorization is different, but has the government considered reviewing the system? There are complaints from patients, and with the number of complaints, number of complaints actually reflect the work of HA. And can you draw any experience on the complaints received? Any lesson to be learned? Dr. Chen. Now let me take your questions on medication. In any serious untoward event, the HA immediately would review the situation and analyze the error and see what lesson we can learn from it. I think the HA will supplement in a moment, but I think what the HA is doing is to enhance the clinical management system. That is a computer system so as to enhance the capability of the database, monitoring of prescribed drugs, or a prescription system for inpatients. These will help monitoring the existing situation and prevent such incidents from happening. Well, is Deputy Secretary talking about the use of iPad or digitizing the prescription? No, it's a computer system. So you combine the number of complaints and the statistics of SEs and SUEs and draw a lesson. Let me take this question. On quality and safety, we shouldn't just look at the SEs or SUEs statistics. We look at the number of areas. But SEs consisting of 9 categories represent a benchmark internationally recognized, but again there are also a number of complaints at the annual meeting every year. There are the number of complaints are disclosed and categorized, and there are clinical and non-clinical factors. We may not be able to draw a lesson from these complaints, and the number of complaints would exceed the number of SEs and SUEs, and this is a challenge for us. We're still thinking about how to really learn something from the information available. Very often it has to do not only with negligence. Perhaps it has to do with poor communication and bad feeling on the part of the patient, but some complaints are quite serious in nature. And we also consider whether we could analyze the information in complaints sent to the Public Complaints Committee. On the whole, the trend is not on the rise, but perhaps we'll go back and look at the figures again, in particular in the cases dealt with by the PCC. Now on medication, our work is ongoing. Looking back in the past 10 years, some in changing previous practices, we have been able to resolve some problems. For example, handwritten scribbles and the distribution of drugs erroneously to the patient at the next bed. Well, these problems have been resolved because of change in the system. About another problem we have a matching procedure to be taken with the computer system, and typos and other minor errors can be avoided. As for inpatient services, it is a great challenge across the world as far as the computer entry is concerned, because we need a smooth procedure, and we mustn't give access to every staff to the system. And so far, 3 hospitals have seen the project being implemented. And if we do away with the hiccups, the things will become more smooth. In the 3 hospitals, with the implementation of the system, we don't see any statistics of SEs and SUEs. Rather, there are more complaints in relation to more complaints against doctors. But we think this is important, and we're going to make an effort in the next few years.
As for we have established a learning process concerning SEs. There are some rare incidents. How can we inform all the frontline staff about this? Now, lately we have an incident about infusion pump, and 3 micrograms should be used. However, instead 100 micrograms were used. So how come this happened? It turns out that the pump setting was problematic. There were 2 brackets, that is one for 1 pump and the other for the total capacity. That's the difference between 30 and 100. So when you look at the pump, and if you're standing and looking at the pump, you may get confused. So a mistake was made at that point. Now, of course, you may say that there should be double checking. However, the design of the pump does have problem, and this may happen elsewhere. So our challenge is that how can we tell all our staff, and infusion pump is a high-risk instrument. It may jeopardize the lives of patients. So we have identified this new focus, and we want to make improvement. We want to disseminate the message to all our staff. So this is something ongoing. Dr. Au, just now Dr. Kwok asked about the number of complaints. I understand that's an annual report on complaints of the HA. That is about the overall complaints. If you're interested, those data are from the Public Complaints Committee. So can you consider giving us that information so that our members would have a clearer picture? Chairman, I agree with the chairman's request. So next time around, can you give us the figures? In particular, when it comes to PCC, we want the data and analysis. That's very useful. So please send us the reference information. I think it should become a regular information to be provided to us. Mr. Poon Siu Ping. Quality and safety are very important for patients. I would like to ask a simple question. For 2013 to 14, there have been 20 cases about retained instruments or other material after surgery. So what kind of instruments were retained? Do you have a categorization? And paragraph 11 is about the rapid development or the rapid technological advances in medical care and procedures. And it makes many effective treatment possible. This, in turn, has increased the complexity of the surgical procedures, as well as the types and variety of equipment used during the procedures. So, do you mean that it's because the treatment is more complicated, so it's more likely that instruments would be retained in the patients, and also you have a timeout process. So what's how is this process different from the existing procedure? And I would also like to ask a question about manpower. You may say that these incidents may not be caused by the lack of manpower, and you are going to streamline work procedures, to hire more supporting staff so that the frontline staff's pressure can be allayed, etc. So how much workload are you talking about? Is it because many senior healthcare staff have left, so that's why there's a serious manpower shortage? I think the HA can give you specific information concerning your questions. For your first 3 questions, or for the first 2, is about the 20 cases of retained instruments or other material. Well, for those 20 cases, 12 of them are about broken instruments or materials. Maybe the HA can give you more information. And you just asked about complexity. I think Dr. Au can also supplement. As for retained instruments or other material, internationally, mainly you will find cases in which gauge is left inside patients. But now we are more careful. We would attach a lot of importance to counting. Each year we will have just 3 to 4 cases, but we have numerous surgeries each year. As technology advances, in the past, we didn't have similar procedures. For example, in the past, we wouldn't carry out a procedure inside an X-ray room, but now we can do a lot of things inside an X-ray room. You can even inject solutions into a person's kidney. So in operating theaters, the procedures are very strict. But if such procedures are performed in other places, there may not be such strict procedures. So that's why we would enhance the timeout process. We will be promoting or advocating a timeout process in other places that are not already using it. And also we have outreach nurses. And when the nurses clean the wounds of patients at their homes, mistakes may happen, and it's very difficult to count the number of pads or gauges at the patient's home. So that's why there were these cases. As for these 20 cases, as the Undersecretary pointed out just now, 12 of them were related to broken instruments or materials. Some surgeons have argued with us. They said that this may not be the mistake. Now, because if you use a drill, the tip of the drill may break off a bit. If a small piece of iron is left inside the body of a patient, it actually would not harm the patient, and it's not the surgeon's fault. But when it comes to categorization, it's very difficult for us to look at such minute details. And also, there are drain tubes. We would use tubes to drain patients' liquids. In the past, we just use a very simple plastic tube, but now the procedures may get very complicated. You may have to put it or sew it onto the kidney, etc. So it's not as simple as the way we do it in the past. We cannot just ask an intern to pull out the tube. So it's like medication era. We have solved traditional problems, but there are new challenges. Ms. Mei Kun. Now for the 9th centennial events. What are the definitions? I have seen some cases. Oh, I think you may know this case. After an examination or after a blood test, the blood test result was put in a drawer, and after the patient's death, the report was found. I would like to clarify this. Now, for these 9 categories, we made reference to international practices. And also at that time, Hong Kong did have this kind of problems. For example, category 8, infant discharged to wrong family. We did see it in the past. Well, this was the starting point for our categorization. These were the essential events that had to be reported. I remember last time when I came to Electrical, I talked about the United Christian Hospital. We talked about the pathological reports, and also there were some outdated medicine used at QEH. Well, can you tell us more about AIRS? Well, under our present system, we have a computer reporting system. So no matter how serious or how minor the incident is, you have to report. And we have a filter person who would look at the incidents. And if he thinks that the incident is serious, it would be escalated to a higher level, and an independent panel will be looking at it. It would also be made public, and we would explain to the patients, etc. So for these 9 categories, they are indicators so that we can compare ourselves with other countries. I understand that the Department of Health also wants to unify these, and it hopes that the private hospitals would also use these 9 categories so that we can speak the same language. But we would not omit other important incidents. We would look at each case very carefully. However, each year we just have less than 10 or a dozen cases like this. Yes, I hope that with this system in place, there will be less untoward events. However, unfortunately, I still hear from time to time such cases.
Sometimes the patient might have died, and when their relatives came and complained, it was only later that it was discovered, the error was discovered. And how would these cases be dealt with? Of course, we would assist the family members, but what about the HA? How would these cases be dealt with? Some cases had to do with not just a single incident. It may have to do with the use of wrong medicine, or having conducted a blood test and yet the result was not available. So about the systemic problems, how will you deal with it? And the Department of Health, it will also streamline the cases in public and private hospitals regarding sentinel events. And I agree with that, because for private hospitals there are even more sentinel events, and patients or family members even need to pay before the deceased relative is discharged. So there are some incidents that are quite obvious, and the doctors would take the initiative in reporting the incidents. But there are other incidents that are only subsequently discovered by family members. So how would you deal with that? I think Ms. Alice Mack is talking about medical or sentinel incidents or untoward events discovered in the process of lodging complaints. And how will you deal with that? Dr. Au. In fact, this is the same as what I said just now, and I want to clarify that immediate reporting may not be necessary. Even after a patient died, if an error is discovered, then a report could be made then. So, internally speaking, these incidents will be dealt with. Now, about complaints. Unlike these categorized incidents, things may not be very clear whether it's due to a doctor's error or otherwise. So we need to take a holistic view on the complaints and the conclusion before we could say whether any frontline staff or any doctor has committed any error and whether they should pay attention to certain matters. And of course, we try our best in trying to identify learning opportunities among the complaints received on the PCC. We have another team to follow up on complaints. Perhaps the two teams should put their heads together and discuss the matter. Dr. Helena Wong. I have a number of questions. First, on inpatients committing suicide. In 2013-14, there were 19 cases. I also note how structurally, in terms of fitting or structure, something would be done. My question is whether you've considered medical social workers in hospitals or pastors in hospitals, whether you have sufficient manpower. For some reason, patients may be very unhappy in hospital because of the illnesses, and would visits be arranged to follow up on these cases so that we could push down the number of suicides in hospital? Would you review that? Thank you, Dr. Wong. For the 19 cases of inpatients committing suicides, 10 committed suicide whilst on home leave. But whether the patient is in hospital or on home leave, what patients are they? Mental patients, gynecological ones, or what? So that we know better why patients on home leave would commit suicide. Any information, Dr. Au? Thank you, Chair. Now, like Deputy Secretary said, out of the 19 suicide cases, 10 patients committed suicide whilst on home leave, and 2 patients went missing when they committed suicide. So only 2 committed suicides whilst in hospital. Now, we would think that many of these suicide cases had to do with patients with depression or mental illnesses, but in fact many had to do with cancer. 7 cancer patients, in fact, and also patients suffering from other terminal illnesses, lung diseases, and they were suffering a lot. And some patients were at the preliminary stage diagnosed with cancer, and there were 2 cases involving patients with schizophrenia. Now, we discussed with the quality and safety staff across clusters a number of times already, and there are different approaches. For example, the professional assessment could be improved. There should be a formal assessment on the patient's risks of suicide. Even when the patient is on home leave, before the patient is allowed to leave, a more professional assessment should be made. But the limit is that when the patient is on home leave, it's difficult to keep the patient in case of emergencies in hospital for an assessment. With so many patients, it's simply impossible. And in some other situations, this may not be the cause. With such a heavy workload in hospitals, it's really difficult to have some human touch in hospitals, so to speak. That is, there may not be time for patients to be heard. So what about some soft intervention? So yes, this is what we're thinking about, and see whether we can have voluntary workers, voluntary groups paying visits to patients apart from pastors. There could be volunteers with different religious beliefs paying visits to patients. This could be the main line of communication. We're not passing the buck to volunteers, but when they visit the patients, they could also note their emotions. Now, about half of them committed suicide during home leave. So it's not the case that the doctors have discharged them. No, the patient's discharge should not be counted, because the international standard is that for inpatients, when hospitalized, you have the duty to watch over the patients. But Hong Kong is unique because very often we allow inpatients to go on home leave, and this is unique in Hong Kong. So for patients who may want to end their lives, as I heard just now, not many committed suicide were mental patients. So would you give more support to these patients? As I think that's what Dr. Helena Wong meant. Well, for patients who wish to die, they might have remained silent for a while already, or they might not be readily willing to communicate with others. Some cancer patients might be optimistic, but in terms of risks, I think we should give this more concern, because the consequence may be serious. Yes, do work with the Social Welfare Department and see if you can collaborate on certain initiatives. You're talking about the people committing, or inpatients committing suicide whilst on home leave, and a while ago in Oyman Estate, just within a day, 2 inpatients whilst on home leave committed suicide. So the figures are really staggering. Apart from caring for these patients, their physical conditions, we need to consider whether they believe they are beyond help and they would like to end their lives, and we should consider what resources are available to help them. Dr. Fernando Zhang. Thank you, Chairman. The reporting mechanism on SEs and SUEs has increased transparency, but we do receive a lot of complaints against SUEs in our ward offices. In 2009 and in 2011, Mr. Chen Ka-fu's motion was carried. He proposed that an independent commission be set up or to deal with complaints against HA. These complaints ultimately may go to the Medical Council, but 24 out of the 28 members of the Medical Council are doctors, and it's easy to see how they defend themselves within the profession. Most of them are co-workers or classmates in Hong Kong U or CU, and the procedure could be very lengthy. In a recent case involving celebrities, the proceeding took as long as 9 years. Ordinary people wouldn't have the resources or the capability. And if you visit the Medical Council's website, it's all in English. It's not user-friendly. And in 2009, according to government statistics, from 2009 to 2013, there were 2,362 complaints, but only 142 complaints were subject to inquiry. That is 6%. Substantiated complaints, even less, 4% only. So disputes over sentinel incidents in the end often would not be resolved. 4% of substantiated complaints is very low. Of course, in the paper, you already explained that the idea of setting up an independent complaints office is not useful. But the point is, at least we could shorten the procedure to less than 5 or 6 years. So will you face up to the problem? The LegCo actually passed the motion twice, and you just regarded us. Of course, you have been disregarding us anyway, but please explain to us. We understand the problem with, or the difficulty with complaints, and the HA is improving the procedures and see whether each case should be dealt with independently, and as to whether the case should be referred to the Medical Council, the HA is actually reviewing the system. Well, may I remind members that we're talking about SEs and SUE management. Now, of course, we can talk about complaints, whether complaints are handled properly, and I'll let the administration answer. But it's in para 20.
Dr. Ao. Oh, with regard to the communication between the Medical Council and the HA, lately we have talked to the chairman of the Medical Council, and now we have a better understanding of each other's stance. There is one thing we can do now. If the Medical Council has started investigation into a case and it wants more information concerning the patient, then HA can help relay that request to the patient. In the past, there was some difficulty in this area. That is whether the HA should hand the patient's information over to the Medical Council. We do not see many cases a year, but there are indeed serious incidents which involves investigation. And after the investigation, if it is discovered that is indeed the healthcare officers' problem, then perhaps we should refer the case to the medical council. This is still being considered, and Dr. Zhang Weihong is still looking at this. But we have communicated with the medical council, and now things have improved a bit. But of course, it's not about the independent medical complaints commissioner. I think the HA can consider this. When it comes to complaints, there are not so many complaints against HA doctors. And among the 400-odd cases, only 60 to 70 are about HA doctors. So under the HA, can you also set up an independent complaints mechanism that would offer better protection to the patients? Is the PCC independent? The chairman and the membership, no matter whether they are directors or members, they would not intervene in the procedure and they would not exert any influence. If they decide to summon anybody, they would also do the decision, make the decision independently. So the PCC is not under any of our departments. My department would provide secretariat support to the PCC. So they are very independent when it comes to handling complaint cases. I know there are still controversies. That is whether it is better than having a medical ombudsman. This may be the direction that we can take into account, but nothing has been decided yet. Mr. Ban Chen. When we look at the categories of sentinel events, most of them are about surgeries or suicides. But when it comes to death of patients, the public is actually very, very concerned about one thing. That is, when you go to see a doctor, the doctor misdiagnosed or he omits something, then the patient misses the best opportunity for treatment. So is this kind of case reflected in your figures? And also for private healthcare providers, I think they have been thriving in the past few years. In the future, if we have medical insurance or universal medical insurance, there may be more healthcare providers like this. So do we also see this kind of figures in your statistics? And are the doctors more senior doctors, or are most of the doctors senior doctors or junior doctors? Because the public is very concerned that they will become guinea pigs. With regard to the figures, maybe the HA can answer your question. As for your second question, we haven't done our classification in accordance with the seniority of the relevant healthcare worker. No matter whether a person is senior or junior, the most important thing is to learn the lesson and move forward. I would ask Mr. Au to answer your question, and later on I can answer the question concerning private healthcare providers. As for senior and junior doctors, we do not have the relevant information because lately we have seen more incidents. So that's why we've made an analysis. Each July we will be having new housemen. So we have looked at different seasons and tried to find out if there would be more incidents when there are new housemen, but we haven't verified this trend. And as for unsatisfactory treatment results or delayed treatments, can this be regarded as incidents? Internationally, this is not the way they categorize incidents. Because medical treatment is not a 100% foolproof technique. For patients with lower belly ache, how many of them would really be suffering from appendicitis? So we have asked doctors to be very careful. They shouldn't miss any case. Maybe they should also look at other areas. But if you want to cast the net wider, there may also be other problems. So a balance must be struck. And when it comes to medical treatment, we have to look at this balance. And you asked about the responsibility of doctors. If they are indeed found to be responsible after an investigation, then what will we do? But we cannot use this as a yardstick to measure all the cases. We will not count cases like this. Any supplement from the Undersecretary? Yes. Some members mentioned private doctors and hospitals and what are their systems concerning SEs and SUEs. We have issued a paper on strengthening the regulation of private medical practices. We hope that we can make public and private hospitals standards more consistent. Yes, tomorrow we will have a public hearing on this. Chairman, I am not too concerned about the seniority of doctors. When I look at Annex B and C, you have set out a number of sentinel events by categories and SEUs by categories, but we do not know where these events happen, in which hospitals. So can you tell us which hospitals would see the most cases, or is there any hospital that hasn't seen any one case? And have patients asked for compensation? If so, what's the amount they claim? And did you penalize the medical professionals involved? And what were the penalties? Dr. Au? Well, we don't have a breakdown of hospitals, but we look at the clusters. As for the distribution among clusters, each year is different. We do not have a cluster which is known to be the worst. As for the 7 clusters, well, Kowloon West serves the most patients because it has the most hospitals. So as a result, they have more SEs. Among 49 cases, they have 13 cases. And for NT West, they may have limited resources and manpower. Is there a tendency for them of having more cases. They just have 4 cases, so they are also doing not too bad a job. So we haven't seen a pattern, and we cannot over-interpret. So for Kowloon West, do they mainly happen in a certain hospital? No, we haven't looked at individual hospitals, but I can go back and take a look at it. Can you give us the relevant information afterwards? Yes. So what's well, compensation and penalties involved? Well, these were the figures of the previous few years. If there were prosecutions or settlements, we still cannot see the figures yet because we only have some older figures. These figures are all rolling. So in my hands, I do not have the most updated figures. And also some of the prosecutions may involve cases other than these 9 categories. Lately, I've been looking at healthcare insurance, and it seems that the number of settlements has been declining in the past years. On the whole, there was a declining trend. That is, not many cases involving compensation were found. How about sanctions or penalties? I do not have that figure now. Maybe I can provide you with the figure later, but it's similar to civil servants. There are different types of warning, such as oral warning, written warning, and reprimands. The most serious case, as far as I remember, the relevant officer was prohibited from promotion. Now for the SEs, can the relevant figures be more transparent? Can you upload these figures onto the HA website so that the public would know, and the public can also monitor the HA's performance? I think the public has the right to know. They should know what's happening to our public healthcare system. And in the future, I think they should also know about the operations of private hospitals. Would you consider making these SEs public? I think they have sentinel reports. Dr. Au? Other than our regular reports, do you mean that we can report on all the hospitals or each hospital? Well, Dr. Helena Wong wants to see the figures. She also wants the figures to be published online. Well, we have had an initial discussion about that. I've asked the clusters what would happen if such figures are made public. If you ask the clusters, of course, they do not want to publicize such figures. Well, Ms. Wong, we are not debating this.
Yes, you should let the public know the performance of hospitals and doctors, and the disclosure should not be subject to the doctor's consent because otherwise we won't know a thing. All right, so much for this item. This is the last meeting in the year of a horse, the last regular meeting this year. Tomorrow we have a special meeting. Members, please come on time. Thank you.